Hello, everyone. My name is Jessica Pranke, and I'm really excited to be speaking with everyone today. I have the pleasure of presenting the Impact with Aegis webinar today, and our topic is around the MDS and therapy's contribution to that. So our title is Unlocking the Power of Collaboration, the Value of the Therapy Professional's Contribution to the MDS. There's a couple of things that I want to review before we get into the topic for today. First, all of the lines will be on mute, so please use the chat feature for any questions. Our moderator today is Shyla, and she'll be taking a peek at any questions that come through, and hopefully we'll have some time at the end today to answer and talk through some of your questions. If you do happen to be joining with any other attendees today, if you're sharing a screen, please do inform Shyla through the chat that you are doing that and provide her with the email address of any other attendees. Course certificates will be sent out within 1 to 2 weeks, and any SLPs joining today, if you would like to request ASHA continuing education credit, you will need to complete the ASHA bubble sheet and return that back to Shyla within 1 week from today, so that would be the 24th. And then AOTA does require OTs and CODAs that are participating today to pass an exam. So Shyla will send out a link to the OTs and CODAs the day after the course for the quiz. I believe there will also be a QR code in the handout for that quiz as well. So OTs and CODAs, you must pass this quiz to get credit. The deadline is going to be the same 1 week from today, and you do have 2 chances to pass. Today's presentation will be about an hour long, and we'll try to get to as many questions as we can after the presentation. If we aren't able to get to your question, or you'd rather not ask it here, please feel free to email me directly. I'll provide that email address to you shortly. All right, just a little bit about myself. I am a speech-language pathologist, and I am RAC certified. My current role is National Director with Post-Acute Care Solutions Consulting, or PACS Consulting. We are a consulting branch of Aegis Therapies, and we have several service offerings, including MDS coding consultation and therapy management services. I am a salaried employee of Aegis Therapies, and outside of that, I do not have any other relevant financial or non-financial relationships to disclose. On the screen here, you can see my email address. And again, I am available for any questions or discussion after the call via email. I did just want to mention that today we're sharing information in our presentation for general educational purposes, and it is accurate as of the date of this slide deck and the finalization of that slide deck. Today we're going to talk about a lot of different aspects of MDS coding. We always recommend seeking guidance directly from the RAI manual for coding instructions and other CMS manuals as needed. Our discussion today will be mainly focused around Medicare Part A, PDPM reimbursement methodology, payer type. So I won't necessarily repeat that as we kind of talk through some scenarios and opportunities for collaboration, but just note that we will be speaking directly to that particular payer type. We have 3 main objectives to address today. We want you to leave today's presentation being able to really explain the basics of PDPM reimbursement as it pertains to therapy. We also want you to be able to explain areas of the MDS that pertain to therapy components as well. We'd like you to look at implementing systems for collaboration and communication tools as a therapy professional to support collaboration, supportive documentation, and the completion of the MDS. And then also discuss key therapy focus areas from some of the case studies and scenarios that we'll share today related to the MDS and quality measures. So we'll begin with some brief background on the MDS and around those PDPM fundamentals. So Shyla, just so that we're all on the same page, we are on slide 5. We're really ready to get into the presentation now.
Perfect.
So thank you. Yeah, I'm sure everyone on the call is well aware that on October 1st, 2019, several years ago, reimbursement methodology for Medicare Part A transitioned from the RUG-4 model to the patient-driven payment model, or PDPM. With the RUG-4 model, there were approximately 1 or 2 items on the MDS, and our funnel on the left-hand side there on the slide shows us that. Most of you probably recall that it heavily focused on the quantity of therapy minutes delivered. And then shift, and we see on the right-hand side, we see that under PDPM, we have many more. We don't even have enough circles on the slide to show you how many items on the MDS are used for reimbursement under PDPM. It's said to be approximately 150 to 200 items used for reimbursement under PDPM. And because of this increase in the number of items on the MDS that are used for PDPM reimbursement, there's really been an increase in awareness and discussion around the MDS, in particular in the therapy world. And I happen to think that it's a really great thing because the MDS is a tool that's used for many other clinical reasons outside of reimbursement. Next slide. So what is the MDS? The MDS stands for Minimum Data Set. Our current version is 3.0. It's really one of the 3 basic components of what's known as the Resident Assessment Instrument. The other 2 are the CA, or Care Area Assessment Process, and the REI Utilization Guidelines. So the utilization of the 3 components of the REI yields information about a resident's functional status, their strengths, weaknesses, preferences, as well as offering guidance on further assessment once problems have been identified. As therapists, we really tend to focus more of our understanding and communication around the MDS and use of the REI manual as well. Next slide. The MDS is a core set of screening, clinical, and functional status data elements. It includes common definitions and coding categories, which form the foundation of a comprehensive assessment for all residents of nursing homes certified to participate in Medicare or Medicaid. The data elements, which are also referred to as items in the MDS, standardized communication about resident problems and conditions within nursing homes, between nursing homes, and between nursing homes and outside agencies. Next slide. So here we've pulled some direct language around the resident assessment instrument, and I want to just cover a couple of things here. So the purpose is outlined, part of the purpose I should say, is outlined on our slide here, but I do want to highlight again some of that language that we see. So the second line quoted on the slide states, clinical competence, observational, interviewing, and critical thinking skills and assessment expertise from all disciplines are required to develop individualized care plans. The REI helps nursing home staff gather definitive information on a resident's strengths and needs, which must also be addressed in an individualized care plan. So here we see some language around all disciplines, right? All parties working together to develop that individualized care plan. Next slide. We've got another quote here, same area, with some additional language really starting on line 3 on the quote here on the slide. And it states, nursing homes have found that involving disciplines such as dietary, social work, physical therapy, occupational therapy, speech language pathology, pharmacy, and activities recreational therapy in the REI process has fostered a more holistic approach to resident care and strengthened team communication. So again, here we see that need for our input on the MDS and for this process. And we often do that, right? We pass along information and our observations. We do that in our documentation. We do that verbally, oftentimes in meetings. But I really would love to have you think about your particular team, your facility, your community during the rest of our discussion. And just think about, are there opportunities to strengthen some team discussion, to strengthen the collaboration, your perspective from your scope of practice and discipline? Is there anything that you can do to facilitate that? Or is there a communication tool that you may be using that could use some sprucing up, or maybe there's a tool that is needed. All of these things really continue to keep our resident, our patient at the center of our team's focus. All right, next slide, please. Okay, utilization of the MDS. So with the implementation of PDPM, again, we tend to think about the MDS as it pertains to reimbursement, as I mentioned earlier, and that's absolutely one use. You see that in that green box on the slide. But it's important to remember that over time, the various uses of the MDS have expanded. So its primary purpose as an assessment instrument is to identify resident care problems that are addressed in an individualized care plan and monitoring the quality of care provided to nursing home residents. The MDS contains data elements that reflect the acuity level of the resident, including diagnosis, treatment, an evaluation of the resident's functional status. MDS assessment data are also used to monitor the quality of care in nursing homes. So MDS-based quality measures, or QMs, those are derived from data collected on the MDS. They were actually developed by researchers to assist with the state survey process, nursing home providers with quality improvement activities and efforts, and also nursing home consumers in understanding the quality of care provided. So the MDS in this process is really multifaceted and clinically focused, as you can see. So Shyla, we're going to go ahead and please launch our first polling question. And our question for all of you on the call is, for those patients with the patient must be receiving physical therapy. I'm so sorry, Shyla. Do you have the first one launched? Could you read it, please?
Sure. The patient must be receiving physical therapy and/or occupational therapy for a patient to qualify for a PDPM PT/OT case mix group.
Thank you. I wanted to make sure we had the right one pulled up. Perfect. So our response options here are true or false. So we're going to wait and see what you all think about this. Thanks so much, Shyla.
You're welcome.
So we'll just give you a little bit longer to respond to that. Does our response look pretty good, Shyla?
Yes. So I think we're good to close it now.
Sounds good. So our correct answer here is false. So the PDPM case mix groups are calculated for each resident regardless of whether they're receiving PT, OT, or SLP services. So all residents will have a classification regardless if they are participating in therapy.
So 72% said true and only 28% said false on that one.
Okay, good. Well, thank you for that's okay. So let's just cover that again. So the patient must be receiving physical therapy and/or occupational therapy for a patient to qualify for a PDPM PT/OT case mix group. So we're going to talk about it in the next couple of slides, but again, just to reiterate, that is false. The patient does not have to be receiving therapy in order to be classified in any of those therapy case mix groups. So if we took PT and OT out and we said speech, it would still be false, right? So the patient is going to be classified in a PT, OT, SLP component or CMG case mix group, regardless of whether or not they're receiving therapy. All right, let's go to the next slide and we'll kind of dig into that a little bit more. So a couple of slides to cover PDPM. Our PDPM components here, so again, patient-driven payment model. Several years we've been in this reimbursement methodology. It is a step in implementing a reimbursement model with patient needs at the center, and you see that in the visual there. PDPM consists of 5 components. So we've got PT, OT, speech, nursing, and NTA, which is non-therapy ancillary. So those are our 5 components. PDPM, again, has a more patient-focused approach to reimbursement versus our previous RUG-4 model. So if you were familiar with the RUG-4 model, it was obviously heavily based on quantity of therapy minutes. And now in PDPM, it's really based around patient characteristics. So for today's discussion, I'm not going to review nursing and NTA, but we're going to look at PT and OT and speech a little bit closer. So we'll go ahead and go to the next slide, please. All right, PT and OT. So PT and OT are classified in the same case mix group, but they have different case mix index or indices. So that's a more complex kind of topic for another time, but really want to, again, cover the fundamentals. So PT and OT component have the same variables to determine the clinical category, or like I should say case mix group. So one of those is the clinical category. This is determined from the medical diagnosis that's entered in I-20B on the MDS. So that's typically a nurse or an MDS coordinator that does that on the MDS. The coding instructions for I-20B on the MDS is the reason for the SNF stay. So what's the reason of why that resident needs that SNF stay? And that's different from our previous instructions, which were really around reason for the hospital. The second factor here is for PT and OT component is the function score, and that comes from section GG on the MDS. So there's actually a calculation, but it's derived from section GG scores. Also note that nursing component, even though we're not going to cover it today, it does also use section GG to determine the function score for the nursing case mix group. Let's go ahead and go to the next slide, Shyla. And we're looking at the SLP component here. So it's a little bit more complex because it has additional characteristics. So 5 different characteristics or groups versus the 2 we had for PT and OT. So we do look at these 5 characteristics. CMS outlines them into 2 different tiers or categorizes them into 2 different tiers. So the first one are those top 3 that you see. It includes the presence of an acute neuro condition. This is determined by the medical diagnosis, same thing for PT and OT, that goes into I-20B. So that reason for referral, that medical diagnosis in I-20B could potentially qualify the patient for a presence of an acute neuro condition. The second is the presence of a cognitive impairment. This is from the scoring of the BIMS or staff assessment. The third factor in the first tier is SLP-related comorbidities. These are diagnoses that are outlined by CMS that qualify for the presence of the SLP-related comorbidity. So CMS tells us what codes will qualify. Those are noted in section I and or O on the MDS. That second tier is the presence of a swallowing problem. That is going to be identified in item K0100A, B, C, and or D. And then the last item is mechanically altered diet. That is noted in K0520C3. So we're providing you the item numbers or the sections, just again to increase that familiarity. Some of you we're on the SLP side, some of you may be actually coding K0100 on the MDS. You may be coding K0520 on the MDS. With PDPM, diagnoses, conditions, and services may be present and active for a resident. The nursing team therapy, we might be addressing these needs from a clinical perspective. However, if we're thinking about PDPM reimbursement, if it's not coded on the MDS, since the MDS is what sources that reimbursement, it will not qualify, right? So it's important to note that coding on the MDS requires supportive documentation in the medical record, right? We are capturing what exists for that resident. Furthermore, kind of thinking back to the multiple ways that the MDS is used, there's a risk for not thoroughly capturing the patient's clinical presentation and care planning needs on the MDS, right? We want to make sure that the clinical aspect is there. All right, next slide. The next 3 slides are going to cover criteria for skilled stay. So I'm just going to hit the highlights here, but I think it's really important to remember that the criteria for skill did not change with the shift to PDPM. So we still need that documentation to support coverage guidelines. That's important. Daily skilled services are defined as skilled nursing services and or rehab services. So it can be one or the other or a combination of these services, and must be needed and provided on a daily basis. Now, there are specific things that qualify for skilled nursing services, so I won't go into that, but that's important to note. The Medicare Benefit Policy Manual has language around this. I've quoted it on the next couple of slides. Again, I think it's important to note a patient whose inpatient stay is based solely on the need for skilled rehab would meet the daily basis requirement when they need and receive those services on at least 5 days a week. So let's go ahead and go to the next slide, Shyla. And I'll just kind of pick out a couple of things I want to discuss because sometimes there can be confusion around this. So again, this requirement, and this is quoted from the Medicare benefit policy, but this requirement should not be applied so strictly that it would not be met merely because there is an isolated break of a day or two during which no skilled rehab services are furnished, and discharge from the facility would not be practical. The daily basis requirement can be met by furnishing a single type of skilled service every day or by furnishing various types of skilled services on different days. That would collectively add up to daily skilled service. So last point here is really important. It says, however, arbitrarily staggering the timing of various therapy modalities through the week merely in order to have some type of therapy session occur each day would not satisfy the SNF coverage requirement for skilled care to be needed on a daily basis. And we'll go to the next slide, please. All right, so last slide here again, just to address skilled stay. To meet this requirement, that top bullet there, just want to highlight that. To meet this requirement, the patient must actually need skilled rehab services to be furnished on each of the days that the facility makes such services available. It's not sufficient for the scheduling of therapy sessions to be arranged so that some therapy is furnished each day unless the patient's medical needs indicate that daily therapy is required. So you've got an example there. It's just, again, highlighting the fact that there needs to be a legitimate medical need for scheduling a therapy session each day in order to meet that daily basis requirement. All right, next slide. All right, one note here about, a couple notes I should say, about ICD-10 coding selection or code selection, in particular as it relates to medical and treatment diagnosis for therapy. So I did want to include a couple key points here. It's always been a very important area for us as therapists, and it has some heightened focus and relevance under PDPM. We talked a little bit earlier about the SLP component, those SLP-related comorbidities. Again, those are ICD-10 codes. So again, that's where that heightened relevance under PDPM comes in. As therapists, we are reviewing the medical record. We're selecting documented medical diagnoses that provide information regarding what contributed to this functional change of the patient that I'm addressing. That medical diagnosis must be woven into the reason for referral section of our plans of care. It's also really important to include the details on the cause of that functional change within your therapy discipline scope of practice. And then we have our treatment diagnoses in our plans of care. Those are what will relate directly to the focus of treatment and medical conditions or concerns that we'll be addressing. So when we talked about the PT and OT SLP components for PDPM, we talked about I-20B. We talked about that medical diagnosis in I-20B. And so that is a factor in the classification. However, I did just want to note that there's not any specific guidelines requiring the therapy plans of care to include that medical diagnosis that's entered in I-20B of the MDS. I do know that there may be some preference or policy or practice by our partners, our customers, to include that diagnosis. And if that's the case, then we would just recommend including any other medical diagnoses that are appropriate and pertain to the cause of that functional change for your discipline and reason for referral. So it can still be included, but just make sure, obviously, that we're really mindful of including those diagnoses that support our plan of care. Okay, Shyla, I think we're ready for polling question number 2. And the question is, there are approximately how many items on the MDS that are used for PDPM reimbursement? So our possible responses here are A, 0, B, 1 to 2, C, 150 to 200, or D, over 1,000. So I'm going to wait, and Skylar, just if you don't mind letting me know when we look close.
Okay.
Thank you. How are we looking?
Looks like 61% has voted so far.
Okay. What's the favored response?
Right now we are sitting at 1% think 0, 6%, 1 to 2, 87%, 150 to 200, and 7% over 1,000. Give
Okay, thank you.
everyone just a few
Yeah,
more seconds. Looks like there's a little bit
perfect.
going on.
Thanks so much.
All right, and we'll close it and ended with 87% at the 150 to 200.
All right, well, majority definitely rules in this case. So yes, we talked about this on our slide with all of our funnel and our bubbles, right? All of our different areas for items on the MDS. So the correct answer is C, 150 to 200 items approximately. Perfect. Okay. Let's go ahead. We'll go to the next poll. We've got our third polling question here. And the question is, therapy services alone cannot skill a resident. If the resident doesn't receive therapy, they shouldn't receive Medicare Part A benefits. So is that true or false? So how are we looking?
We've got 63% voted and 86% of you said it was false.
Okay, do we want to wait a little longer, or are we good?
I think we're good.
Okay, so that's right. The answer is false. Remember, daily skilled services are defined as skilled nursing services and or skilled rehab services. And so either combination, right, must be needed and provided on a daily basis. Very nice. Okie doke, let's go to polling question number 4. So our question here, or our polling question, is therapy must use the ICD-10 code that represents the reason for the SNF stay as a medical diagnosis on their evaluations for it to be skilled under Part A. Is that true or false? How are we looking?
All right, it looks like 75% of you say true and 25% say false.
Okay. So I'm so sorry. So 25% false, 75% true?
It ended up at 76% true, yes.
Okay. So our correct answer here is false. So we certainly can include that diagnosis, but we don't have to. We certainly can, and as I mentioned a couple slides ago, we may have a partner preference or policy, or customer preference or policy or practice that they are requesting that. And again, that would be perfectly fine. It's not a requirement. But we would also want to make sure we're including any medical diagnosis that contributed to the functional change of the patient in order to support our treatment. So it very well could be that that medical diagnosis in I-20B, that reason for referral it does meet that criteria. It is what contributed to the functional change of the patient in order to support our treatment. It may be that there was another factor or another medical condition that contributed to that functional change. So hope that is clear. Again, not required, but certainly can be done. The goal is really, again, to have those medical diagnoses to support your treatment services, right? All right, let's go to the next slide. And what we're going to do next is we are going to talk through some case studies, some scenarios related to PDPM therapy and the MDS. We'll also, as I'm talking, I'm going to incorporate just some discussion around the importance of collaboration as we talk through these. And I'll also share some communication tools that have been created to help with collaboration and communication among the team. So go ahead and go to the next slide. All right, so our first case study or scenario is pertaining to section GG. And I'll highlight, again, kind of our scenario here, and then we'll talk through it. So therapy reports that during their evaluation, a resident requires setup, cleanup assistance for eating and oral hygiene, and partial MOD assist for bed mobility, transfers, and walking. The MDS team uses only these ratings for section GG on the MDS. Later, upon further review, it's noted that nursing documented on multiple shifts during those first 3 days of admission that the resident required setup, cleanup, assist with eating, substantial max assist for bed mobility, transfers, and walking. So here, what I really want to highlight is that this is a case, turned into a case of collaboration and consideration of input from all disciplines, right? Initially, we are seeing only therapy scoring or ratings of that GG making it to the MDS. But in this situation, we also have nursing documentation that demonstrates the performance of that resident. So the ideal situation is have that team review and really consider all ratings to determine the resident's usual performance over the 3-day assessment period. As therapists, you're documenting the task completion in the medical record, which ultimately should align and support the coding of the MDS. But the MDS coordinator is who will report the usual performance on the MDS. So therapy and likely nursing documentation is reflecting an actual performance at the time of the GG assessment for each activity that's completed. So important to kind of be aware of that whole process and that scenario. So a couple of things to consider. For those of you that are rating section GG activities, how confident do you feel in what you're rating and the rating criteria based on the REI manual guidelines? So do you feel pretty confident? I know exactly what I'm rating, and I know my scoring scale. I know I'm rating it correctly. Have you taken some recent training? And do you use any tools to help you with that process? And then kind of thinking from a team perspective, what does the decision making around the scoring on that MDS look like for your team? How do you provide your input from a therapy perspective? Are you a part of a team discussion? I'm sure we have therapy team leaders on the call. What does that process look like? So again, some things to consider. All right, let's go ahead and go to the next slide. So section GG has quite a bit of impact, and you'll see the 4 areas outlined here. And for those of you on the call that have been through EACHS training, this is going to look really familiar to you. So one area GG impacts is around communication. It helps to communicate functional challenges and abilities to guide care and discharge planning. It also is used to publicly report the facility's ability to improve or maintain function. And Medicare uses the section GG functional scores to compare one nursing home to another. So that, again, publicly facing information. This information is publicly displayed on the Nursing Home Care Compare website, with performance ratings reported separately for short stay residents and long stay residents. We'll take a look here at an example. And then remember, we know it's also used to establish the SNF Part A daily reimbursement rate, right? So it's used for 3 components like we talked about earlier, PT, OT, and nursing. And then in some states where we have Medicaid case mix using the PDPM reimbursement methodology, we have had some shifts over the last several months. It may also be used. And then lastly, it supports the efficacy of our services. So we need accuracy of baseline and final measures to show how our services and treatment benefited the patient. Section GG activities, they're used to display functional outcomes, right? To show the benefit of therapy involvement. And to show the actual outcomes of your patient, it's going to be critical to score the patient accurately both at the time of eval as well as discharge. That admission and discharge scoring paints a picture for the overall improvement of your patient. So certainly a factor with reimbursement, but you can see several other areas that Section GG impacts. All right, we'll go to the next slide. All right, so this is an example of nursing home compare for the short stay SNF Part A residents. Really just wanted to share this again. We talked about that publicly facing information. This is quality measure, that's a percentage of patients. We've got it for a couple different areas using those Section GG scores. So again, just really understanding that Section GG has quite a big impact in a lot of different areas is important. Next slide, please. All right, so the accuracy, we really can't overstate this enough. The accuracy of GG items are so critical that accuracy really matters. It is dependent upon really 2 things. 1, the understanding of what activities are involved in the tasks you're measuring, and then knowing and using the scoring scale appropriately. Both of those things combined are going to get us to that GG item accuracy. Let's go to the next slide. Because this is a tool that we feel can help us get there. So this is an Aegis Impact developed resource that uses the instructions and language directly from the REI manual. It's 2 pages. I've just obviously pulled out the screenshots there. And we asked all of our therapists to actually use this when they're scoring Section GG. We've made it available to our customers as well. At the very top, there are some important reminders when scoring. The top section is a rating grid, so it takes you through that independent to dependent based on the Section GG definition. It also provides you with the definitions for the 4 options when the activity is not attempted. And then each task with the assessment steps, again, using that REI manual language and information, really walks you through what do I need to be assessing for each activity. When does the assessing or the measuring start, so to speak, and when does it end? That way we're not putting our own interpretation around what should be assessed for an activity. If we were to look at eating, for example, I think if we did another poll and had some open narrative there around what does that mean to you, we would all have a different experience around what that means, based on our experience, on what we've, our skill, our scope of practice. And that's really important to note, that we don't want to make assumptions around what activity is being scored. We really need to use the REI manual definition. And then on the far right-hand column, there is some assessment tips. So these tend to be more specific considerations for each task. So again, whether you use this tool or you use another tool out there, we do really recommend having one handy during your assessment of the GG items. All right, let's go to the next slide, which is actually, we're ready for our next polling question. So our question here is, again, 5th polling question. Our question, or our what we're proposing here, is the GG item accuracy consists of, and then we've got a couple of options. So the first option is appropriate task assessment and time of day assessed. Our second is appropriate task assessment and appropriate scoring methodology. Third is appropriate scoring methodology and quality measures. And the 4th is none of the above. And we'll give you guys a second to respond to that.
All right. 5% say it's appropriate task assessment and time of day assessed. 72% appropriate task assessment and scoring methodology. 17% say it's appropriate scoring methodology and quality measures, and 5% say none of the above.
All right, well, so I think in this case we have another majority rule. So the correct response is appropriate task assessment and appropriate scoring methodology. So that's, again, that's the key to Section GG accuracy, right? We want to make sure we understand what we're assessing. That's our task assessment. What tasks are involved, or what activities are involved in this task that I'm assessing, I'm measuring, and what is the appropriate scoring methodology? Do I know what scale I'm using? Perfect. Okay. Thank you, Shyla. Let's go to the next polling question. So we're on our sixth polling question here. And the question here is, for those residents receiving therapy, only the Section GG scores obtained by PT and OT should be considered. And I'll just add, for coding on the MDS. So for those residents receiving therapy, only the Section GG scores obtained by PT and OT should be considered. So is that true or false?
All right, Jessica. 84% said false, 16% said true.
Okay, thank you. Yes, so the correct answer is false, right? So therapy is not the only team that can provide the scores, and it's really recommended, again, based on REI manual guidelines, that it is a collaborative process within the team. So very good. Thank you. Okay, let's go to our next case study scenario. So next slide, we should be on slide 30. So here we have a newly admitted resident that has an active medical diagnosis of COPD and uses oxygen. She is observed to have shortness of breath while lying flat during her PT evaluation. The PT discusses this condition with nursing, who also states they've observed this as well. The PT and nursing do not document this condition in the medical record. So here we see an example of good communication, right? Good verbal communication between the PT and the nurse. They talked about it. They said, yep, we both are seeing the same thing. But what's missing here, big miss, is that there's no documentation that's making it to the medical record, right? PT didn't document based on our scenario here, and the nurse did not document either. So if it's not documented, it's likely not being coded on the MDS. And if it is coded on the MDS, then we have a really big risk that there's no supportive documentation, right? So if shortness of breath, which is one of the items on the MDS, if that's coded and we don't have that supportive documentation, we're at risk. Our other kind of problem that we have here is that it exists, but we didn't get it documented. Didn't make it to the MDS perhaps either, right? So the condition should be documented for clinical reasons and considerations. The documentation, when we document, it helps each caregiver and provider be informed about the resident's condition, right? It's a way for us to communicate with one another, and it also may be missed from a care planning perspective if it's not documented. So it's a way for us to know what's happening with our residents. And this also happens to be a situation where the classification of the PDPM nursing clinical category, I know we did not go into that in detail, but in this situation, it would be impacted as well if it didn't make it to the MDS. So again, this means that the resident is not going to be classified really in the appropriate category from a clinical perspective, because we have a condition that exists, but it's not getting captured. So again, thinking about your practice in this situation, is this something you've encountered? Do you proactively provide input or assess shortness of breath while lying flat? If you do you make sure to document it? Do you make sure that that's communicated to the MDS team member. And I think, again, this is a scenario that we really could input different medical conditions, right? It may not be shortness of breath while lying flat. We could probably think of some other scenarios here as well where we would want to make sure we have that documentation and that communication. All right, let's go to the next slide, please. All right, our next case study or scenario is around Section K or swallowing problems. So we have a resident that is observed to cough while eating her breakfast. She also reports some pain when swallowing her morning medication. So the nurse documents the resident complaint in the medical record, also advises her physician, and also advises the SLP. The SLP receives physician orders to evaluate the resident and actually completes the evaluation on the day after the assessment reference date, or the ARD. So we're going to, for the case of this scenario, say that that nurse documented the day before the ARD, right? So that documentation happened within the look-back period on the day of the ARD. Physician provides orders, the SLP evaluates the day after. So I think the important thing here to note, again, is we've got some good news, right? The good news is we have documentation in the record. The other good news is that the SLP is notified and gets involved, right? That's great. That's clinically what we would want to see, both good things. Since the nurse documents the observation in the record and it's within that look-back period, then it could be captured in K100C and K100D. It can be captured. There's supportive documentation. It represents the clinical presentation of the patient during that look-back period of the ARD. But I just want you all to kind of take a second to think about what would have happened if the nurse had not documented the swallowing issue, still reported to speech still got involved, but during that look-back period, the nurse just did not document it in the medical record. It didn't make it in there. So again, that would put us at risk for not capturing a clinical characteristic of that resident. The other piece is ensuring that there's some communication here, not only from that clinical perspective, but we also want to make sure that anytime, even after the ARD, if a change in condition occurs, right? And it may be that we're not always aware as therapists what the ARD is, depending upon the dynamic in the facility. But even after the ARD, if a change in condition occurs, it's really important that we're communicating that in case perhaps there's another assessment that the MDS coordinator would need to complete. So there are other times where there would be an assessment completed. So communication is key, right? Even if it's after, before, we want to make sure we're communicating anything we observe. All right, let's go ahead and go to the next slide. So one way to really funnel that really important information that we gather as an SLP at any point in time during our involvement with the resident is by using, again, some form of communication process, some form of tool. So here's just an example of one that was created by Aegis and PACT. It, again, doesn't have to be complicated. It can be just some fashion of a tool, ensuring that communication and collaboration is taking place. There are times also, we talked a little bit earlier, right, where SLP may be using a diagnosis that would qualify for that SLP-related comorbidity. Is that communication happening? So this tool really doesn't take the place of supportive documentation, but it helps us to facilitate that there's information in the documentation to ensure everyone is aware, right? We want to make sure that your perspective as an SLP is considered. So how do you do that currently in getting that information to your MDS coordinator? All right, let's go to our next slide. This is actually our last polling question. So we can launch that, Shyla. So our question here is, the SLP notices a new swallowing problem for a resident after the ARD. Should they let the MDS coordinator know? Yes or no? And I'll just say, I realize there's probably therapists that provide this information to their DOR or their therapy manager. And sometimes there's communication that happens from the therapy leadership to the MDS coordinator, but the sentiment is really the same, right? should we ensure that we're communicating this new swallowing problem? So Shyla, I will lean on you to let me know when we're ready.
We'll give them a couple more seconds, but so far 100% have said yes.
Okay, good.
All right, I think we're good.
All right, perfect. So do we have yeses? Mostly yeses?
100% said yes.
Great, perfect. So that's the answer we would kind of lean towards, right? So yes, we already talked about this. We want to make sure all parties are in the know, right? From a clinical perspective, we need to make sure nursing is aware, doctors are aware. If they're involved with PT and OT, we want everyone involved in that resident's care to know. So really important. All right, let's go to the next slide. And our last case study, our last scenario is related to the patient health questionnaires, the PHQ, right? PHQ 9, now it's really PHQ 2 to 9, the resident mood interview. And our example here is we have the OT providing the PHQ to the resident. For item D0150A, little interest or pleasure in doing things, the resident, when asked how often they have been bothered by little interest or pleasure in doing things, responds, "There's nothing to do here. All you do is eat, bathe, and sleep. They don't do anything I like to do." So in this case, the OT assumes, well, that means that the resident really isn't experiencing that symptom, so I'm going to mark down no for symptom presence. So our problem here, right, is that the OT in this scenario isn't using any of those really, really, really critical interview techniques outlined in the REI manual, and we've got a couple of them. So without interviewing according to those guidelines and using those techniques, we really can miss that true clinical picture of the patient. So a possible solution here would be that the OT who is interviewing says, "You're saying there isn't much to do here, and I want to come back later to talk about some things you like to do. Thinking about how you've been feeling over the last 2 weeks, how often have you been bothered by little interest or pleasure in doing things?" So that possible solution, that response, would actually be an example of the echoing technique, one of the ones outlined in the REI manual. It's used when a resident might give a long answer and you want to narrow those response choices available. So it's useful to really summarize that longer answer. All right, so let's go to the next slide. We've got some impact here of the PHQ that I'll cover fairly briefly, but there are really 3 major impacts here. So first, it's used to help direct clinical treatment. It can help identify signs and symptoms of mood distress among residents, and those signs and symptoms can be treated. Secondly, again, care planning purposes, right? We want to make sure that the care planning occurs if needed. Information directly from the resident helps to inform the care plan, make sure it's individualized. And then the third, again, ties to reimbursement. It can have an impact on the nursing clinical categories under PDPM as well. So if you're in a case mix state, again, for Medicaid, it may be that this is also an impact there as well. Let's go to the next slide. And this is just highlighting those 5, again, interview tips and techniques that are in the REI manual. Please email me if you'd like to talk about these more, or you would like to review them. Again, available in Section D of the REI manual. This is the key to really providing this type of interview. You want to make sure you're getting a clear picture, and you want to make sure that you have that resident's voice. That's actually what it's called in the MDS. You want that resident's voice for the MDS. All right, next slide, please. All right, so what are our key takeaways? So I'm thinking of everything we discussed today, just kind of pulling it together. Our key takeaways here is really, you want to make sure you're reading and following any REI manual instructions for sections in which you're providing input. So if you're doing the PHQ, if you're doing the BIMS, you're completing Section K, you want to make sure, of course, that you've read those instructions. And then periodically review those instructions again, make sure that you're up to speed. You also want to assess we hope at least that you're assessing your current role at the facility to determine if there's an opportunity for improvement of communication systems and processes. So kind of looking at how you communicate and how the team communicates, are there any opportunities for that? Using communication or collaboration tools, so maybe that needs to be created, maybe you have some that exist that can be modified. So thinking about a GG resource or a GG guide, some type of SLP communication tool, communication around ICD-10 code selection. And then, of course, documenting clearly and thoroughly, right? Our documentation can be the support of coding on the MDS, and we want to make sure that we are always documenting clearly and thoroughly. So really our last slide are our resources. I've included that there. And I know we're got about 3 minutes, so we can do maybe a question or so. Again, if you weren't able to get a question in the chat or we don't get to answer it today, please email me and we can talk further. So Shelly, do we have any questions?
We don't at the moment. There have been a couple that Shannon, thank you, Shannon, has answered in the questions. So if we have any other questions, I'd be happy to read. One person says, where do I email my ASHA form? So you will email it to me. My email is Shyla, SHYLA .Hamrick, HAMRICK @aegistherapies.com. There is a handout. There's handouts in the handouts section. It has the PowerPoint and PDF form. It has the brochure. It has the ASHA bubble sheet and also directions for the OTs and CODAs.
All right.
Again, you find the ASHA form in the handouts section.
Very good. All right.
My email is included in the handout for the CODA. If you guys do not find it, you're welcome to email me and I can send those to you. All right.
Okay. Well, thank you everyone so much for your time today. Really, really excited to have been able to present on this topic, and I hope everyone has a great rest of your day. Thanks so much.
Thanks, guys.